This is Radio Health Journal. I'm Reed Pence. This week, short-staffed rural hospitals facing an influx of critically ill COVID patients.
These small facilities are having to take care of patients that they really don't have the resources or the talent to take care of. They do the best they can.
How small hospitals are trying to stretch their staffs when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
It's a common shock that has caused people to ask lots of questions about how they spend their time and what they value and what they trust and where they are valued.
How has the pandemic fed into the labor shakeup and shortage? Then,
we really only understand a very tiny bit of the universe, and we're still asking really basic questions like, where did the universe come from, and what is it made out of, and how will it end?
Exploring the vast expanse of our endless universe. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
For more than a year and a half, the pressure on hospitals and the people who work in them has been intense. COVID-19 has overrun the normal routine. More patients are sick, and each one requires more help. At many of the nation's small rural hospitals, some with 25 beds or less, the pandemic couldn't have come at a worse time. They were already facing a shortage of nurses and other staffers.
The staffing shortage is critical at this point for rural hospitals nationwide. And this is a long-standing issue that's been plaguing rural hospitals and their communities for decades.
That's Brock Slabaugh, Chief Operations Officer for the National Rural Health Association.
Since and after the pandemic, we're seeing increased pressures on hospital administrators and directors of nurses to keep adequate staffing to accommodate patient loads due to pandemic and pandemic-related illness.
In 2020 and 2021, these hospitals that normally don't run anywhere near capacity at times have been completely full for months at a time. And to the extent in August and September, there was no ICU bed availability and very limited medical bed availability in every region of Texas.
John Henderson is president and CEO of Torch, the Texas Organization of Rural and Community Hospitals. He says while many people are aware that nurses are in short supply, in reality almost every department in many rural hospitals is being stretched to take care of patients.
The shortage applies to, physician staffing, respiratory therapists in particular, but then it extends on down into lab and technical type positions within any hospital. People have performed admirably during the pandemic, but most of them are tired of it, and some that are approaching retirement have accelerated those plans and just decided to sit the most recent wave out.
Being tired of it has become an important factor for staff in just about every hospital, but in rural areas there's less wiggle room to compensate for it.
We're seeing really high volumes, and these are very sick patients, so they're not a pneumonia or patient that presents some average sorts of disease. These are usually, sometimes can be very sick. The other problem is that transferring patients has been very difficult. So you get that sick patient into the facility and you see a drop in their O2 saturation and they become critical in a few minutes, and you got to get them out and transferred to a tertiary or quaternary facility. They find out there's no room at the inn. And so these small facilities are having to take care of patients that they really don't have the resources or the talent to take care of. They do the best they can. And so the burnout comes when staff are having to deal with patients in the conditions for which they're not trained or have skills to be able to really adequately handle.
That creates what Slabaugh calls a vicious cycle, where the problem gets worse and worse.
Because of the shortage, it puts more pressure on the existing staff the existing staff becomes burnt out, and yet when one or more quit, then it just creates more pressure on the ones that are left. So yeah, it just keeps going in a circle, unfortunately, usually downward.
The consequences are far-reaching. For example, Henderson says on 2 occasions during the pandemic, officials had to put a stop on all elective procedures and surgeries at all rural Texas hospitals, and it wasn't just for a day or two.
3 to 4 months in each case, which is remarkable because the rural hospital CEOs report to me that, in some cases, more than half of their revenue comes from those elective procedures and cases. And what allowed them to return to doing the elective procedures and surgeries was when the wave of COVID cases improved and their COVID patients as a percent of their total patients fell below a 15% threshold. So that was the marker. And when things improved below that point, they're able to resume all services, and they all have.
But even now, some needed procedures are unavailable at some rural hospitals nationwide. It can be life-threatening.
We have actually seen examples in rural New York State, for example, of a hospital that has closed their obstetric unit because of staffing shortages. They just weren't able to, with the resignation of a couple of nurses, they weren't able to continue the unit, which is really tragic because we have maternity deserts all across the United States. And we know that distance in terms of travel increases the morbidities and unfortunately even mortality of those that are wanting to deliver babies.
The hospital in Alpine, Texas, which if you know far west Texas, they're a long way from the next community, actually suspended their deliveries because of staffing limitations.
And the staffing shortage could get worse before it gets better as a result of federal vaccine mandates for hospital workers. Slaybaugh says nationwide up to 20% of the workforce has threatened administrators with quitting rather than getting vaccinated for COVID-19. Henderson says he's concerned.
We're Texans. We don't necessarily like being told what to do, but we really don't like being in the middle of a political standoff between the state and federal government. There will be a subset of that. When push comes to shove, they will get vaccinated to keep their job. But there's another subset of that percentage that just isn't going to do it, and they'll walk away from the job before they will comply with a vaccine mandate. So what rural hospitals are doing in preparation is just encouraging but not requiring the vaccination and making contingency plans around service offerings that they can suspend to keep providing essential hospital services like ER.
But will it really be that bad? In Washington state, the governor's vaccine mandate is already in place for hospital staffers. It put threats to the test.
It is reported that the number of people that quit actually at the final moment based on the mandate was less than what they had anticipated, what was told in the beginning. But there were still some people that left. I will point out, like at my hospital when I was an administrator, often one or even two nurses, just using that as an example, can put a real hamstring on the staffing of units. So the small numbers here are that, you could say, well, one or two is not that big of a deal. But in a small rural hospital, that can be critical.
Hospitals are trying to plug the gaps by offering more hours and incentives to existing staff as much as they can. But sometimes that's not enough, and hospitals have to turn to third-party contracts.
Hazard combat type pay, paying a premium just to try to get their existing nurses to take more shifts and meet the local need. But then they also have had to adjust by working more with external staffing agencies and pay, exorbitant rates, but that's what's required. But we've seen double pay for staff to take extra shifts. We've seen bonuses in the neighborhood of $500 extra per shift. And then I've heard from some of the staffing agencies, nursing rates as high as $250 an hour. And the reason I use exorbitant is prior to COVID, we showed average RN pay in rural hospitals to be in the $40 an hour range.
We've seen retention bonuses, hourly add-ons for COVID pay, that it's called, quote unquote, other types of incentives to basically keep people motivated to stay by the bedside and provide care. These numbers are not sustainable. And then, of course, when you look at retention of the current workforce, when they hear one of their nursing colleagues that is standing next to them is being paid through the company $200 and some an hour, then that doesn't help morale for those existing nurses that are in the front lines wondering why they're not getting perhaps some of that same type of pay.
Slaybaugh says incentives work in the short run, but staffers can put in double shifts only so long. Cash can't eliminate burnout or the conditions that have created burnout in rural hospitals since well before the pandemic.
You have the perceptions, the issues, trying to get people to leave the city to go work in rural communities. So you've got that stereotype sometimes to have to overcome. The second issue is we've had systemic underfunding for decades in rural hospitals and rural clinics. So there's been an assumption in public policy that rural facilities are essentially just smaller versions of urban ones. And so payment policies have not been tailored to the small volume environment. And so because of this underfunding, it's caused a constriction of the ability to meet demands in terms of wages and salaries for personnel.
Slaybaugh says as a country, the United States hasn't set up policies to get people to move to rural areas, and medicine hasn't done a good job recruiting those who already live there.
We know from data that the likelihood of somebody moving to or living or working in a rural area rests on two variables. The first is that they were born in or raised part of their upbringing in a rural area, or spent some of their time in training in a rural area. So those two variables really increase the probability of somebody going back to work in a rural community. Unfortunately, those situations are not always present in admission policies to our graduate schools and to schools of professional training. They don't have these kinds of sensitivities to their selection process, and often rural students could be left out of the mix in terms of recruitment.
In the long run, training programs such as nursing schools are the way out of the staffing shortage. But even if rural-based programs are increased, those won't bear fruit for 3 or 4 years at best. The pandemic may not last that long, but the crisis may mean the end of some rural hospitals, creating medical deserts.
Before the pandemic, we had 138 hospitals that have closed in rural areas since 2010. This is very concerning to us, as the provider relief funds that were given to all providers nationwide at the beginning of the pandemic and then has continued through 4 phases. Once those monies start to run out and some of these subsidies are ended, we could see another round of rural hospital closures.
Slaybaugh estimates that more than 450 rural hospitals, or more than a quarter of the total, are in danger of closing. You can find out more about this issue and all of our guests through links on our website, radiohealthjournal.org. I'm Reed Pence.
The beginning of the COVID-19 pandemic in March 2020 shut down many businesses and drastically reduced car and airplane traffic. Now, a new study has linked the resulting reduction in air pollution to a drop in heart attacks. The study was presented at the American Heart Association Scientific Sessions 2021. It correlated a 6% drop in heart attacks with each 10 microgram per cubic meter reduction in one common type of particulate air pollution during the shutdown. Sidney Ong of the University of California, San Francisco was lead author of the study.
Research has already indicated that air pollution is associated with heart attacks and stroke. This real-world example now highlights the importance of reducing air pollution, which could, in turn, prevent heart attacks.
Although the new study could not prove cause and effect, the findings are significant because more than 7 million premature deaths globally were associated with exposure to particulate air pollution in 2017.
I am one of thousands of women with metastatic breast cancer, or MBC,
which is breast cancer that has spread to other parts of the body.
I am living in the moment and taking Ibrance, palbociclib.
Ibrance 125 milligram tablets with an aromatase inhibitor is for postmenopausal women or for men with HR-positive, HER2-negative MBC as the first hormonal-based therapy.
Be in your moment. Ask your doctor about Ibrance and visit Ibrance.com.
Ibrance may cause low white blood cell counts that may lead to serious infections. Ibrance may cause severe inflammation of the lungs. Both of these can lead to death. Tell your doctor right away if you have new or worsening symptoms, including trouble breathing, shortness of breath, cough, or chest pain. Before taking Ibrance, tell your doctor if you have fever, chills, or other signs of infection, liver or kidney problems, are or plan to become pregnant, or are breastfeeding. Common side effects include low red blood cell and low platelet counts, infections, tiredness, nausea, sore mouth, abnormalities in liver blood tests, diarrhea, hair thinning or loss, vomiting, rash, and loss of appetite.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
Homeless people really are us. They're just a much, much less fortunate subset of us.
Myths about the homeless and why those myths end up blaming the victim.
Then becoming a first-time father in your 40s or 50s. What's it like being an old dad to young kids?
I often get mistaken when I'm with my kids at a supermarket as their grandfather. They'll say it explicitly. How are your grandkids today?
All that and more on Radio Health Journal.